Thanks. Thanks for coming to rounds today. We have Dr. Nicholas Bowers. For those who don't know him, he's been a great resident fellow for quite a few years. He actually grew up in the Waterloo area, went to undergrad there and came to Toronto to do his medical school, did his cardiology residency, then had been a fellow at Sunnybrook for the past 3 years, I think. He did 2 years of interventions. He is doing his structural heart disease fellowship now, and he's actually going to the US to do more fellowship in Columbia next year. So I think that, it's, I kind of want, this year I've asked kind of all the fellows who have been here for some time and particularly leaving to give rounds so that, we'll at least get to know them. We really have to know that what they have learned over the past few years. So Nick is going to present on one of his main interests and something that he is going to do in the near future, which is structural heart disease. So he's going to talk about future directions of structural heart disease. He's going to talk about a little bit of a history about the cardiac intervention as well as aortic and mitral. So thanks a lot, Nick, and thanks for all your work over the past few years. He's really had been the glue that holds our interventional program together. So take it away, Nick.
Thanks a lot, Dennis. Okay, so this will be future directions in structural heart intervention, and nothing to declare. So I'd like to start with reviewing some of our history in structural, what we might see in the future, and challenges associated with innovating in structural heart disease. And we'll separate it by aortic and mitral valve, and then some final thoughts on the future and where we're headed. So if you look at Tavi as a 20-year history, we just hit the 20-year anniversary. In 2002, the first Tavi was performed in France by Professor Cribier, and that's him on the right side here, and that's in Rouen, France. And this started a journey that really started in 2010 with the first trial was the Partner B trial, which was poor surgical candidates, essentially prohibitive candidates. And this was Tavi versus medical therapy or doing nothing. And that showed mortality benefit. And soon after that, we had a trial, a Partner A trial, which was high surgical risk. This is Tavi versus surgery. And there was no mortality difference between the two, suggesting that Tavi was a reasonable alternative for these patients. So we proceeded on to do lower and lower risk patients. In 2016 was intermediate risk, and this showed Tavi was non-inferior to surgery. And most recently in 2019, low surgical risk, younger patients with this showing lower risk of death, stroke, rehospitalization with Tavi versus surgery. So an incredible journey over 20 years, starting with the first in human and now proceeding to low surgical risk patients, and essentially giving us data that the two approaches are quite similar in their risk and very feasible. So where we are today, particularly at Sunnybrook, is doing 4 to 5 cases per day. And some centers do 5 per day regularly. It's a 50-minute procedure, 40 to 50 depending on the device. The access is transfemoral in almost all of the cases, a much smaller profile access, so 18 French compared to 25 French initially. Complication rates are low comparatively to where we started, and also just in general. And most patients go home the next day, same day discharge is possible and sometimes done. So it's really transformed from 2 procedures per day, very high risk, to now 4 to 5 per day easily, with patients going home the same day. And the journey is incredible. And the question is, where are we going to go from here as it's become so streamlined and so effective? So the next wave will include expanded indications. And for everybody who thinks that we do enough TAVIs already, this is likely heading towards more TAVIs in the future, more days needed, more cases needed to accommodate all of these indications. So I'd like to go through a couple of trials for moderate AS and a couple for asymptomatic AS, and then discuss TAVI in younger patients, which is a separate issue altogether, and as you'll see, a bit more complex. So moderate AS, defined by the ECHO criteria, is a wide range of gradients of 20 to 40 millimeters of mercury for the mean gradient. Usually we would monitor these patients every 1 to 2 years with repeat echoes, but until recently, the natural history of moderate AS is really not that well studied, and at some points it's been thought to be more of a benign condition that we can watch and wait, but as you'll see, there's some new evidence that perhaps it's not as benign as we thought, and making an argument for expanding intervention into this area. So, for example, in the European guidelines, patients who have moderate AS undergoing surgery for cardiac surgery for another reason, it's a 2A indication to replace the aortic valve, which does lend itself towards some argument of intervention at a lower threshold. So several studies have demonstrated risk of death, heart failure, hospitalization in patients with moderate AS is not low, and quite high in terms of statistics on a lot of these observational studies. So as we've demonstrated that moderate AS is not benign, there is argument to lower the threshold. And this fits well with the safety and advances in TAVI, as the delivery systems have become smaller, the safety profile is better, that perhaps now that we have a lower risk alternative, the risk-benefit balance is potentially now in favor of proceeding with intervention on moderate AS patients. So, and related to this is the low-risk TAVI trial, the partner trial, showing safety benefit in these lower risk patients. Perhaps this lends itself to the moderate AS patients as well. So 2 trials underway for moderate AS are the Expand TAVR 2, which is a Medtronic trial, and the Progress trial, which is the Edwards Sapien. And as you'll see in these trials, it's usually a parallel between Medtronic and Edwards performing similar trials to essentially show the same outcome with each of their devices, which helps bring them to market for these indications. But you'll see it in AS and you'll see it in some of the mitral trials we'll discuss. So in the Expand TAVR 2, which Sunnybrook is starting this month, I just did my training on this trial. It's 650 patients using the Evolute valve, randomized 1-to-1 with moderate AS to TAVI or surveillance or medical therapy. And the outcome is similar to the low-risk trials, which is a composite of mortality, heart failure, and needing an intervention on the aortic valve. It's a superiority trial. And as you can imagine, in a lower risk indication, the follow-up needs to be a long time to show durability and performance of the valves as we expand the indication to lower risk people. Now, this is just from the protocol, the population being moderate symptomatic AS patients, at least NYHA2, randomized 1-to-1 to TAVI or to medical therapy. Then in a parallel fashion, the Edwards Sapien 3 is a very similar trial, similar number of patients randomized to TAVI or surveillance, and that's with the Sapien system. A similar time frame, over 8 years to 2029. And the outcome is essentially the same as in the Medtronic valve. And this has been a parallel as well with the low risk TAVI trials, that there's a Edwards trial for low risk, and then there's an Evolute Medtronic trial for low risk. So I think this will exist for the future, that both companies will perform similar trials to show similar outcomes, but support each of their devices. So that's
Nick. Just wondering, for these moderate studies, like what is the gradients criteria? And number two is that, do anybody in this trial get open heart surgery? For example, like, now would be suitable patient, they become severe, they go, traditional aortic valve replacement. Like, do these trial have any surgery in it, or are they all like even like severe kind of TAVR type of thing?
Both of these trials are severe TAVR. You'll see in the next set, the asymptomatic trial, they have a mechanism to proceed to surgery if they become symptomatic or if they are on a stress test. And the criteria for gradients is the traditional 20 to 40 millimeters of mercury for mean gradient, as you usually would grade the.
Okay.
So in asymptomatic AS, it's another area where a lot of the time in the Tavi clinic, we'll see somebody with clear severe AS and watch and wait for 6 months or a year as they're completely asymptomatic upon clinical assessment. And again, it's a Medtronic and an Edwards trial looking at similar outcomes. And some of the background of this is that traditionally from the early studies, the onset of symptoms was a marker of mortality in AS if untreated. But these were small studies, a lot of them actually bicuspid. So it is the traditional teaching, but the data may not apply exactly to this patient population. And as there's no proven medical therapies to reverse or attenuate AS, intervention with surgery or TAVI is the only effective treatment. And usually we offer an intervention when the benefits outweigh the risks. And as we have lower risk therapies, this allows us to propose a change in the threshold. Traditionally, class 1 indications have been symptomatic AS, so this would be a major change from the current guidelines. And as we have expanded access to echo, the detection of AS has become more readily available. And interestingly, 50% of patients with severe AS have no symptoms on initial diagnosis, which leaves a lot of patients who may not proceed towards an intervention immediately. Symptoms can be undetected as patients adapt to this, so they do less, they're walking less to avoid symptoms. And then symptoms also are a subjective assessment, and some patients may minimize symptoms. So we might be missing a group of patients who would usually benefit from this in terms of symptoms, but also subclinical effects such as cardiac stress, damage, sudden death could occur if symptoms aren't reported. And guidelines do recommend proceeding with the GXT in asymptomatic AS patients to unmask symptoms. But in clinical practice, this is not done very much. And part of that could be physical limitation of these elderly patients who do have severe AS, as well as just clinical practice in general. So usually for asymptomatic severe AS, watch and wait approach with echo every 6 to 12 months is the recommended way of proceeding. But similar to the moderate AS patients, the asymptomatic severe AS patients, it's not a benign situation and significant risk of having heart failure and even mortality. So just like with moderate AS, as we have safer procedures and advances in technology, proposing a change in the indication and the threshold seems reasonable. So the first trial, the asymptomatic AS Expand TAVR 1 trial, is by Medtronic. It's a smaller trial than the Edwards trial, but randomizing between TAVI and surveillance or medical therapy. It's a single arm, so it's essentially a safety and performance trial, and completing up to 2027. And primary outcomes of mortality, stroke, MI, AKI, and vascular complications. The Edwards trial using the Sapien system is a larger trial, 900 patients, and this is randomized TAVI versus surveillance. a multi-center randomized controlled trial. This is completing much sooner in 2024 and similar outcomes as the other low-risk trials. So I think from an asymptomatic AS perspective, we'll have more data from the Edwards trials sooner. And this is a larger randomized controlled trial, which would likely, if shown to be a benefit, would advocate for expanding indications to these patients for TAVI and potentially guideline changing in a similar way to the low risk trial being guideline changing. So this is what I was talking about, the mechanism of switching over to receiving an intervention. So starting off as being considered asymptomatic, this was either on history or with a negative stress test. And if you were truly asymptomatic, randomized 1-to-1 to TAVI or surveillance. But if you became symptomatic or you had a positive stress test, then you would enter into a registry of AVR either with TAVI or surgical valve replacement. And this is not an uncommon situation. I've seen several patients in the TAVI clinic just the last 4 months where they initially were asymptomatic in January, and then they came back in March and they're symptomatic. And then at that time, we recommend proceeding with TAVI. So that would eliminate those groups that were watching and waiting and potentially could offer TAVI at that first assessment. And again, this early TAVR trial is Edwards with the Sapien 3 or the Sapien 3 Ultra. And the other trial is with the Evolute, but a smaller, more of a safety trial. So TAVI in younger patients is a more complex situation that I'll try to explain. I think there's a lot of unknowns and a lot of different thoughts on how to proceed with this. So the low-risk TAVI trial, the Partner 3 trial, included younger patients. The average age was 73, but the outcomes were up to 1 year, and it was not designed for the purpose of trying to demonstrate that young patients should undergo TAVI. It was just a low-risk trial. A lot of questions come up repeatedly about durability. And while that's important, the lifelong management plan of a patient with aortic valve disease is probably the more important focus as you plan a sequence of interventions. And using durability data to plan that rather than just durability at the outset and then making one decision. But patient education and informed consent is very important as potentially a younger patient agrees to a TAVI, being important to know that there likely will be further interventions in their life, and we'll need more evidence in this age group. So this is actually an article that I had on an email a couple of months ago, and the title sounds attractive, but as you dig into it, I'll give an example of why it is very complex to deal with TAVI in young patients. Interestingly, on this email, sponsored by Edwards at the top, which is important to always think of who's sponsoring what you're reading. But this article was based on a registry from published in 2021. It's mostly European groups. And in the registry, it reported that patients older and younger, when they separated them, older and younger than 70 years old with severe symptomatic AS were equally likely to die in 5 years from TAVI. But this was an observational study. It should not be used to broadly support TAVI in younger people because this is all patients who received TAVI. So these were, if they're younger than 70, there's a reason they received TAVI, and that's likely that they're higher risk to begin with. So imagine a 65-year-old who has cancer or renal disease or a lot of comorbidities, and surgery is a suboptimal option. Then they're included in this registry because they received TAVI, but they're not the run-of-the-mill younger person receiving TAVI. And while the Partner 3 trial, which was the low surgical risk TAVI trial, had a younger age of 73 compared to 83 in the initial TAVI trials, it was not designed, again, to show that Tavi would be the best way to proceed in this group of people. So while interventionalists might encounter young patients who undergo Tavi, they're at high risk to begin with. And if they have a prognosis of 3 to 4 years from cancer or other comorbidities, and you're able to alter that with Tavi, then that's different than having a 65-year-old who's otherwise healthy, where you need to plan the next 20 years of their aortic valve disease. So what we really need is randomized data in a large trial, similar to all of the other Tavi trials or this asymptomatic or moderate AS trials, but it's a bit different to organize this and fund this from an industry standpoint because of all of these questions about younger patients and is it ethical, is it feasible? And so it's unlikely that a trial like this will be developed and funded anytime soon. And I have not heard of any trial like this that is in the works in the same way that the other moderate AS or asymptomatic trials are proceeding. But when we talk about Tavi in younger patients, the valve-in-valve is a very important technique to deal with these younger patients where you're planning the next 20 years of their life. And it's not unlimited, the number of valve-in-valves that can be performed. Generally, it's one valve-in-valve that can be performed, and there's limited space within the annulus, particularly when you have a surgical valve with leaflets and stent, and then you're putting another valve inside. So generally, one valve-in-valve can be performed in each patient. And in patients who undergo surgical valve replacement, usually it's in their 60s. This is 2016 data, but between 60 and 70 is the majority of patients undergo a surgical valve replacement. So if you take that as a starting point to plan the next 20 years of their life, that's an important number to start with. Durability data is, late data is lacking, so long-term data is lacking. As you can imagine, patients from the original Tavi trials who were very high risk in 2010, a lot of them are not alive, so data from them is not available. What we do have is data from the Notion trial, which was 2014, showing 6 and 8 year data. This is with the Medtronic Evolute valve. The deterioration was actually lower in the Tavi group than the surgical valve replacement group. We don't really have much more robust data than this to determine durability. And some bench simulation studies have shown good durability, but that's not real life data. So one approach that valve centers use is first taking, for example, a 65-year-old and determining what is their life expectancy based on the usual life expectancy tables, which would be 21 additional years for female and 18 for male. And then for this, the goal of a patient who's, for example, 65 would be to get them to their mid-80s, to 85 on average. So a couple of scenarios. This is from a lecture from a heart surgeon at Columbia, New York. What they do is they take a hypothetical patient, for example, 55, and they tried to limit the number of major operations this patient would hypothetically have in their life. So if you took a 55-year-old and proceeded with a surgical valve replacement first at age 55, and that lasted about 15 years on average, then at 70, they would undergo a Tavi valve-in-valve. Then if that lasted 8 to 10 years, they're having a second sternotomy in their late 70s or 80, and then they could have a valve-in-valve later. But this subjects them to 2 major operations. And if the goal from their perspective is to proceed with 1 operation in their lifetime, then potentially in a 55-year-old Tavi first, with 10 years later, a sternotomy in their 60s when they're still younger and recovery is more acceptable. If that lasts 15 years, they undergo a valve-in-valve at 80, which would bring them to their mid-80s. This is an approach that is used, and obviously there's a lot of debate about this, but just showing how the sequence of aortic valve planning for the lifetime of a patient could be the next wave of approaching young patients. Another hypothetical would be a patient who's 70 and opposite to the 55-year-old, if we started with a sternotomy at 70, that last 15 years, they get a valve-in-valve at 85, then this brings them into their 90s and they've underwent one operation, but in their 70s when they're probably a better surgical candidate. This is opposed to starting with Tavi first at 70. If this failed 8 years later, you have a valve-in-valve at 78 and a fairly high-risk surgery in their 80s, at 83 in their mid-80s. So this is a one operation, but in their 80s. And in this situation, when they're 70, potentially starting with a sternotomy first is best to have the one surgery in their 70s. I'm not advocating for this approach, but this is one approach that has been proposed and that some valve centers practice. And I think we'll see more of this in the future as naturally progression of TAVI to younger and younger patients happens. We have to plan for this. And potentially from the outset, their initial intervention will need to be planned with multiple interventions in the future. So many questions remain for this. A big question is the risks of TAVI explant, which there's not actually a lot of experience with this. There's some early data, over 200 patients who underwent explant in a registry, but in-hospital mortality was not low. And the complexity of this surgery, I think, is left to be discovered. And valve-in-valve is not possible in every patient. And so new techniques, basilica, may need to be explored at a higher frequency in more centers, as potentially up to 20% of patients are not amenable to a valve-in-valve. And as time goes on, we'll have more durability data, probably particularly with the low-risk TAVI trials that allow us to follow these patients longer than 10 years after their TAVI. So what does this mean for TAVI? I think this does mean that we'll have more TAVIs in the future. So right now at Sunnybrook, it's about 400 per year, but imagine that number going up is pretty remarkable. But more capacity in more centers as we expand indications. The younger, lower risk, how we get there is unclear, but the natural progression is to move younger and younger. And I think the TAVI trial from 2010 to 2019 has showed a 10-year decrease in this age range. So we'll see how we get there, but I imagine we will. And more redos and more repeat interventions will be needed in the future as we plan long-term management of aortic valve intervention. So I'll stop there. It's about halfway gone through the aortic valve side. Does anybody have any questions about the aortic interventions before we move on to mitral?
I don't see anybody in the chat room. Perhaps if that's the case, maybe you'll go finish and we'll try to have some time for it.
Okay, great.
Dennis, can I ask one quick question?
Yeah, go ahead, for sure.
So Nick, that was great. Any specific recommendations about bicuspid aortic valve patients?
I think bicuspid's a whole other area that I didn't really touch on in this. I think there's ongoing studies in this, but I think there will be a movement towards TAVI and more bicuspid patients, particularly in the younger patients. But for now, it's primarily surgical valve replacement.
Okay, thank you.
And there's another question from Daniel about the TAVR in people with aortopathy. I guess this is kind of similar to bicuspid, but if you have a big root and such, do you have any concern about those?
Yeah, I think again, I didn't really touch on that, but for now, the aortic valve replacement by surgery would be recommended. Okay, we'll move on with the mitral. So similar to the TAVI story, I'll go through a bit of history on this. some devices in development and where we may be headed in the next several years. So the Eclipse story has a similar timeline. 2011 was the first large trial. That's the Edwards 2 trial. And this randomized the MitraClip and surgery. This showed that surgery is overall better in terms of the primary endpoint, but generally, if you received a good clip result with significant reduction in MR, it was a safe procedure. And this led to the next 10 years of data that focused more on MitraClip versus medical therapy as opposed to MitraClip versus surgery. So in 2018, there's 2 studies, the MITRA-FR and the COAPT trials that came out around the same time in the same journal, which was MitraClip versus medical therapy. And they showed differing results, but the COAPT trial had some differences. There was more rigorous medical therapy, there was more severe MR, and probably more experienced operators with lower complication rates. And so I think when we think of our MitraClip patients, they generally align closer with the COAPT patients, where we try them on rigorous medical therapy. We ensure that their MR is severe. And in this trial, there was reduction in hospitalizations, death, and freedom from device complications that was significant at 2 years. So the general takeaway from this data is that in the carefully selected patients with significant MR, MitraClip can reduce hospitalizations, death, and is generally safe. So when I was at PGY4 2017, I presented on transcatheter mitral valve replacements. And at this time, the field had a different landscape than it does now. And I'll show you how 5 years later, there's been a lot of changes. And I think we're closer to a replacement device than the field was then. But mitral replacement has a lot of challenges in creating its innovation. So the anatomy of the mitral valve is very complex, particularly because of anchoring issues and sealing around the annulus. The annulus is not circular shaped, it's essentially a D shape. There's not a lot of calcium often to anchor onto when you're not discussing MAC patients. Preventing embolization and sealing around this D-shaped annulus are some of the challenges in designing the perfect device. And this, you'll see this apical tether technique is used in one of the major devices that's currently being used, called the Tendyne. LVOT obstruction is another challenge, as the angle of the mitral valve annulus in relation to the LVOT can put a patient at risk for LVOT obstruction. And this complicates the design of devices that can be implanted in that area. And the risk of obstruction is not low, approaching 10% in some data sets. And with any new device, durability and degeneration will always be a question. And in the surgical literature, mitral valve replacements are more likely to suffer degeneration than aortic valve, which when the Tavi data of 8 to 10 years of durability is discussed, there would be concern about mitral prostheses as well. So this is back in 2017. There was a slew of devices that I had looked at when I did that presentation. And now 5 years later, a lot of these have been swallowed by other companies or have just unfortunately fallen by the wayside. But 2 of these, the Tendyne and the Intrepid valve, are quite close to coming to the forefront, and I'll show you some of the studies on this. So the 3 I'd like to focus on is the Intrepid valve, which was part of the Apollo trial, the Tendyne valve in the Summit trial, and the Sapien M3 valve in the ENCIRCUIT trial. And this is sort of analogous to the aortic valve space, where the Intrepid is made by Medtronic, the Sapien is made by Edwards, just similar to the aortic valves, Edwards and Medtronic parallel trials. So the Apollo trial is the Medtronic device, which makes the Evolute as well. And currently they're in the midst of a large non-randomized single-arm study with 1,350 participants to show safety and performance of this Intrepid valve. And the history of this is that the device started as a transapical device requiring a mini thoracotomy. And about halfway through, the development of a transfemoral device came to the forefront. And now the trial is shifting towards a transfemoral arm, which would be attractive to a lot of people, transfemoral, transseptal option, rather than requiring a transapical approach. So just in January of this year, published was some of the early data on the transfemoral transseptal Apollo device, which now in the next 10 months is planned to move forward within the trial to have large numbers undergoing the transfemoral transseptal approach. And in this small feasibility study, 15 patients, this was run by largely a group in the United States. From 2020 to 2021, there's 15 implants, one converted to surgery during the index procedure, which comparison to Tavi, essentially 2% or less conversion to surgery would be the rate for Tavi. So keeping that in mind. There's a large number of access site bleeds, but it's a large system, 35 French. But this will be an area of development for this device in the future to make it safer for transfemoral access. But at 30 days, there's no death, strokes, reinterventions, and a significant reduction in MR to trace or no MR, which when planning a replacement device that does have potentially some risks, such as the access site risks, a goal would be to significantly reduce or eliminate MR, because that's one of the issues with MitraClip is the MR reduction is not as robust as you'd want, for example, for a mitral replacement device. So on the right here is some of the data from this showing the reduction in MR at 30 days to none or trace, and reduction in their symptoms. The Tendyne device is probably the closest towards the forefront that of any of the devices right now, and this is one that Sunnybrook has been a part of the Summit trial. It's the transapical device with the transapical tether with apical fixation that does require a mini thoracotomy. So there's no way to implant this valve without a mini thoracotomy and attachment of this tether. And this is a graphical representation of the tether attaching to the apex, requiring the mini thoracotomy, and then the valve gets implanted through that hole into the annulus and then sutured closed. So unfortunately, unlike the Apollo trial, with the Intrepid device that did have a transapical access and now has a transseptal, this one will always be a transapical, probably limiting how attractive it is to the market in general. So the Summit trial is actually completing this year. The device is made by Abbott. Sunnybrook has done one patient within this trial, and it's a randomization of Tendyne to MitraClip. And then there's additional arms, just Tendyne alone for patients who aren't a candidate for both, and then a MAC cohort. And some of the early data from this, the 2-year outcomes, show average age of about 75 years old. Heart failure hospitalization was reduced in terms of its events per year, pre-procedure and after, and a very robust and significant reduction in MR at 2 years, over 90% having no MR. And this is actually the only mitral valve replacement device that is approved in the world right now. So it really is the front runner for this space. But again, the limitation would be that it only has a transapical access option because of the tether, and there's no option for changing this to a transeptal transfemoral device, which would be more ideal. So one other device is the Edwards device, the Sapien M3. So Edwards had another device called the Evoke valve, which seems to not be advancing as quickly. But this M3 system is a two-part system with a circular dock. So this dock wraps around the mitral chordae, and this is implanted transeptal, transfemoral, just like the Intrepid valve. And once that dock is implanted around the chordae, then the valve is implanted within that, and this is the final implant with the two components. And the initial early feasibility study of 35 high surgical risk patients had technical success in 88%. There's one stroke. 30-day mortality was 2.9%. But again, this was an early feasibility study, so some of the really early experience. And this is mostly run out of the Vancouver group and Dr. John Webb. But the Encircle trial is the larger trial analogous to the Summit trial for the Tendyne or the Apollo trial with 500 participants. It again is a single arm, so it's not comparing the device to medical therapy. And these are for patients who have other options being unsuitable. And there's a registry for a failed MitraClip arm as well as a MAC registry. So final thoughts on TMVR. I think compared to the 2017 data that I had presented as a resident, there were a lot of devices in development with very small feasibility studies of 15 or 30 patients. 5 years later, there's leading devices that have large number of patients in trials, 500 to 1,000 patients. And I think we're getting closer, but the time needed to demonstrate safety and performance of these valves probably requires a 5 to 10 year cycle length. And in the next couple of years, I think we'll have large data sets and publication on particularly the Tendyne trial, the M3 valve, and the Apollo trial as that grows in numbers. And it's possible in the next 5 years, there's more devices to market and more options for patients who don't have other options. But I think a takeaway from the transcatheter mitral valve replacement space is that MitraClip, the main benefit is that it is very safe, very low complication rates for the right patient. It's a very good therapy, and that'll always have a place. Similarly to surgery, there's a place for repair, there's a place for replacement, and we'll probably have more options in the future. But for patients who can't undergo MitraClip, there likely will be an expanded set of tools in the toolbox in the future. So some concluding statements and thoughts. I think both MitraClip and Tavi have come a long way in 2 decades. They're different anatomies, different complexities of the valve, different structures. And as Tavi has advanced remarkably to the point where we're doing so many cases so quickly, there still is area to expand indications, and more Tavis will likely be on the way, both here and other centers. Tavi in young patients is a complex discussion, and I think not as simple as potentially the asymptomatic and the moderate AS patients. And while mitral interventions have progressed, there's still work to be done, but I think a lot of work has been done. And it'll be exciting to see where we go with that and what the field looks like in another 5 to 10 years. But in general, it's a very exciting field to be part of. And I think here at Sunnybrook, we're part of a large world-leading program. And it's I always feel fortunate to be a part of it, even in a small way. So thank you for allowing me to present. Hopefully something new was learned and something interesting in this exciting field.
Thanks a lot, Nick. Perhaps you can take down your slides. I know Eric has the first questions. I just want to see whether we can see him as well.
I was actually just clapping hands for Nick's talk.
Okay.
But I do have a comment. But if other people have questions, they should go first.
Maybe you go first, Nick. Maybe you just remove the slide so we can see everybody a bit easier. Yeah, if you unshare, then you.
Oh yeah, yeah.
Maybe I can ask a question again. It's
Yeah.
the issue of MAC. You know, we're seeing a lot of these older patients that have severe MAC. The whole echo assessment in terms of how you quantitate the degree of stenosis is challenging in terms of gradients or some kind of valve area calculation, whatever. But the question, I guess, is really management of these complex patients, usually old and sick and have multiple comorbidities, et cetera.
Yeah, it's a good question. I think Eric would obviously have a lot more insight on this than me, but my experience with this in my time doing mitral was that they are complex, very sick patients with suboptimal options all around, and particularly the calcified patients, when the leaflets are calcified, their clip option is suboptimal, and so replacement devices in those patients may be of significant benefit in the future. And as I showed in a lot of those trials, there's a MAC registry for those patients, and hopefully some of those implants will have a place for those patients in the future. Eric, I don't know if you want to add to that.
I don't want to add too much specific to that, other than to reinforce what Cam already said, that the MAC population is complex. But I think I can add to that. That forms part of a broader comment that I will make at some point before we close up here. I'd like to congratulate Nick, because that's a huge topic to take on, and you have covered it really well without diving into too many details that nobody will remember anyway, and that will probably be untrue a year or two from now. And I really do think the most important bullet point in your entire presentation was the very last one. So just repeat it.
It's exciting field.
Yeah, I mean, it's absolutely been an unbelievable time to be part of unbelievable development, starting from zero and getting where we are. And some of us have been more involved in the mitral side and some more on the aortic valve side, but the overall field of structural intervention has moved dramatically forward, certainly more so on the aortic valve. And I think it's, if you take a little broader perspective, sort of from a history of technology development, it's an absolutely fascinating contrast between what's happened on the aortic and on the mitral side. And just take a second to think about that a bit. But I know in the Tavi clinic, they tease us on the mitral side and say, oh, we're getting nowhere. And we tease them by saying they put aortic valves in almost everybody these days. But the truth is they've advanced at different rates, and there's reasons for that. And if you think about it in a broad sense, most of the population for TAVR is fairly straightforward and homogeneous. It's calcific degenerative AS. And TAVR has actually made slower progress on the sort of fringes of aortic valve disease, of bicuspid, aortic regurgitation, rheumatic disease, and so on. But it's made tremendous progress on the core pathology of calcific AS. And the other thing about aortic disease is that the target disease, at least in its severe and symptomatic form, there's absolutely no question mark about the strength of the indication for an intervention. Whereas severe mitral regurgitation due to ischemic disease that responds to medical therapy, there's always been uncertainty about what to do with it or what to do with degenerative disease where the patient has no symptoms. So the aortic side has had a homogeneous population and a more clear indication. And then the other absolutely crucial thing is that the most basic TAVR technology from the very first procedure, which was crude and primitive in many ways, the one thing it did was it solved the basic hemodynamic problem right from the start. On the first TAVR ever, you could have a lot of bad things happen during or after a TAVR, but the one thing you didn't have at the end of TAVR was aortic stenosis. And if you think about what we've struggled with on the mitral side, is we've done a lot of otherwise successful MitraClip procedures where you still have a fair bit of mitral regurgitation afterwards. So the fact that the technology on the aortic side solves the problem immediately has allowed the whole field to focus on the ancillary issues of delivery systems and paravalvular leak and procedural efficiency, and move on to expand the indications. And the other thing that maybe folks right in the TAVR world don't realize is that I think it's been a fortuitous but huge gain that the two major platforms are backed by two strong engineering companies, but their results have been almost identical. So while there's a lot of sniping between the two platforms of, say, Edwards and Medtronic and balloon expandable and self-expanding, the truth is they've shown mostly the same results, and that has allowed the whole field to move forward into broader indications rather than getting bogged down into whether one platform is better than the other. You can see that that is not the case on the mitral side, where we're struggling between multiple different approaches because of more complex anatomy. So it's really fascinating. I've tried to sort of think of some analogies to other major developments in technology, like Apple versus Microsoft, or the development of powered flight and so on. And I'm sure you could come up with that. But I think this one will stand as an example for a long time.
Thanks a lot, Eric. Anybody else have any comments? Nick, perhaps you haven't touched on the tricuspid space. Do you have like a couple of minutes to say, well, these are kind of obviously niche patients that we haven't really paid attention, but there are a lot of innovations there as well.
Yeah, thanks. A good question. I actually started the talk by having aortic mitral tricuspid, but it was just too much to try to cover at the end. So I think the main thing about the tricuspid is the major expansion of CLIP into the tricuspid space, and the Triluminate trial that Sunnybrook's been a big part of is tricuspid clipping. And the results of this will be available quite soon. Also, there's a lot of appetite for replacement devices in the tricuspid position, and there's an Edwards valve called the Evoke valve that's being used, and there's a trial for that. But similarly, complex challenges in the anatomy of the tricuspid valve, as well as demonstrating benefit, are always challenges in that area. But potentially, in looking at areas that have major room for growth for patients who are underserved, and also for the companies that have motivation to create the devices, if you could demonstrate a benefit in, for example, severe TR patients in terms of mortality or heart failure, and this is essentially an untreated population where they get Lasix alone right now as their main therapy, there's a huge area of expansion that could make this even busier for structural in the future, if that could be demonstrated. So I think the tricuspid clip and the Triluminate will be the first of that, but potentially also replacement devices in the future. And Regine is just reminding us there's a TriClip in service today that you can maybe learn more about TriClip in a few hours.
Sounds good. With that in mind, thanks. I agree with Eric. Thanks, Nick, for giving us really some insights into the valve space. And we all wish your fellowship year next year in New York, because it will be successful. We'll miss you for sure. And thanks for all your help over the past few years at Sunnybrook. So I'll see everybody next week for a different topic. But again, thanks a lot for coming. Thanks, Nick, for doing this today.
Thank you.
Hi, everybody.